Hi everyone.
Hello, can you hear me?
Hello. Hi.
Hello.
Hello. Yeah, Shweta. Hi, Rashmi. Clear?
Yes, clear.
Okay.
Am I clear enough?
Yes, but your video is, I think.
Hi everyone.
You have to rotate it, Prudhwai.
Yeah, you probably have to rotate.
Hi everyone.
Just a second.
Hello, can you hear us, Rashmi?
Yes, we can hear you. Hi Shweta. Hi Rupali. Hi Parul. Hi
Hi.
Prithvi. Prithvi, you need to
Hello.
make sure your video is straightened.
Yes.
Otherwise, Shweta will
Rashmi
be like
is.
this. I'm also trying to tilt. All of us will start tilting now.
Have you joined through your mobile phone?
Me?
No,
Acha.
I'm asking Prithvi.
Shall I admit both? We need to. Hi Shweta.
Hi.
I'm still looking at Prithvi like that.
Yeah, same here.
It's a little
No,
complex.
she's not
Automatic.
seeing.
Hi, Puja.
Hi. Oh, I was waiting in the surgery thing. Thank God I saw.
Rashmi is not seen now.
I'm here.
Rashmi, can I share my screen and see?
Yeah, you can share your screen and check, and then we'll start. It's 3:55. Do you want to? I think all of us are here already. We can start if you want.
Okay, my screen sharing is disabled.
Okay, let me. I will do that.
You can check now.
Okay.
Hi, Ruchika.
Okay, is this visible?
Yes, it is.
Yes.
And if I do this, it goes off. If I escape, it goes off back. I mean, it's not on screen share mode.
It is still screen sharing. You've gone off from slideshow to the entire panel thing. So, but I mean, you'll have to stop sharing to get rid of it.
No, that's fine, but you can't see, you can see my rest of the slides also, right? If I
Yes.
On the left
okay,
side.
okay,
Yeah.
okay. Fine. Yeah. I'll stop sharing right now and then share again.
Yes.
Yeah. Okay, fine.
Mobile silent.
Hello. Am I audible? Hello.
Yes, Ruchika.
Yeah, hi, Ruchika.
Hello.
Yes, Ruchika, you are audible.
Ruchika, we can hear you. We can't see you, but we are able to hear you.
I think she is not able to
Video.
hear us also.
Hello. Am I audible?
Yeah, Ruchika, you're audible. We can hear you.
हेलो हेलो
Yes.
इससे भी नहीं हो रहा
No, we can hear you. Ruchika, we can hear you.
मैं इंट्रोड्यूस नहीं कर नेटवर्क
I've sent a message to Ruchika, so let's see. Shall we start now that everybody is here? All right. Good afternoon, everyone. After a very busy day that we've had today, we are now coming to the panel discussion in the rehabilitation stream. So today's panel discussion is on assessment and monitoring progress in rehabilitation of children post-cochlear implantation best practices. I will be introducing your moderator, Shweta Deshpande, and then she'll take the proceedings ahead.
Kushagra?
Yeah. So Shweta Deshpande is from Pune, India. She's an assistant professor in audiology at School of Audiology and Speech Language Pathology, Bharati Vidyapeeth. She's currently pursuing PhD in audiology at Bharati Vidyapeeth. She's pursued her master's in ASLP from TNMC Nair Hospital. She's been working in the field of early identification and intervention of children with hearing loss since 2006. She's published 7 research papers in international and national journals. So I welcome you, Shweta. And this is a really important topic and a very interesting topic. So we look forward to a whole lot of deliberations. So you can go ahead and introduce your panelists. I'll just move the slides for you.
Thank you so much, Rashmi, for this lovely introduction. And thank you at the outset. I would like to thank the entire organizing committee, the scientific committee of CIGICON, for giving me this opportunity to conduct a session on a panel on assessment and monitoring the progress. And before starting with our panel discussion, I would like to introduce all my panelists to the audience. And first we have with us Ms. Parul Kajalia. She is from Gujarat and she is an ASLP from TNMC Nair Hospital, Mumbai, with 23 plus years experience in the field of audiology and speech language pathology. She's involved in cochlear implant mapping and rehabilitation since 2008, after she has joined Shruti ENT Hospital and CI Center, and she deals with all the 3 cochlear implant company manufacturers. She's currently heading the audiology and speech therapy department at Shruti ENT Hospital and CI Center, Surat, Gujarat. I welcome you, Ms. Parul.
Thank you.
Our next panelist is, can I have the next slide?
Yeah, I'm trying to move the slide. Just give me a minute.
Sure.
Sorry about that.
That's fine. Thank you, Rashmi. Our next panelist is Ms. Puja Bihara, and she has done her master's MSc in speech language pathology from Ayush Mysore. She is a Hanan certified SLP, and she works at Medal India since 8 years now. Her research interests are auditory rehabilitation, bilingualism, and cochlear implantation, and also informal assessment in children with hearing loss. I welcome you, Puja. Thank you for accepting. Our next panelist is Dr. Ruchika Mithal. She has finished her PhD in audiology and speech language pathology, and she has worked for 11 plus years at the Army Hospital at Delhi. And she's presently the director at Mithal Clinic, Advanced Center for Healthy Heart and Joyful Speech and Hearing Center, Delhi, India. She has more than 15 publications to her credit, and she has authored about 4 books. I welcome you, Dr. Ruchika. Thank you for accepting the invitation.
Thank you, Shweta.
Our next panelist is Dr. Rupali Mathur, and she has also finished her PhD in audiology and speech language pathology from Gujarat, India. She's a chief consultant speech and language pathologist at Shabda Brahma Speech and Hearing Clinic and Cochlear Implant Rehab Center, Ahmedabad. She's also a visiting SLP at Jaju Plastic Surgery for Smile Train Program, Ahmedabad. And she was an ex-speech language pathologist at JLN Medical College, Ajmer, also at Civil Hospital, Ahmedabad. Our next panelist, I welcome you, Rupali, and thank you for accepting the invitation. Our next panelist is Ms. Akshaya Prudhwai. She is a senior auditory habilitationist at Trustwell Hospital and also currently a private practitioner. She has done her B.Ed in special education and she has an MSc in psychology. She has more than 13 years of experience in dealing with children using cochlear implants, and she's specialized in developing listening and language abilities in children with hearing loss. Also, she's proficient in counseling family with hearing impaired children and adults with cochlear implants. I welcome you, Prudhwai. Thank you for accepting. Thank you, Rashmi, for these slides. Would like to move on to the panel discussion now. Would be sharing my screen. Please let me know if you all can see it. I hope you all can see the slides.
Yes, we can.
Thank you so much. So this topic, I think, is very close to our heart, wherein we as professionals would really have to scratch our brains with respect to the assessment and monitoring progress in rehabilitation of children with using cochlear implants. And exactly here, we are going to focus on what are the best practices, what are the types of assessment, and how would you like to monitor their progress. Delay, moving on. So as our purposes could be different when we are assessing and monitoring progress for these children with hearing loss and using cochlear implants. But what is our principles of good practice should remain constant. About assessment, we mean gathering information through all different sources, through all different tools or the batteries of tests that we are going to use. And what do we specifically look at is what the child knows, that is their child's strengths, what do the child understands, and what the child can do. So that specifically is what we are looking at. And an assessment should have or look at positive outcomes. And mind you, what we need to remember is we should never label their negatives, or we should never label their failings, or it cannot be limited to what they don't know. So why do we assess is we would like to know their areas of strength, also the areas which are of concern wherein we can work more hard and thus monitor their progress with those aspects which they are lacking in and look at how they have learned it. So when we talk about monitoring progress, it will be overview of the child's development, which is done over time at specific intervals. And I like this aspect, which I took from the National Education for the Deaf UK document, which is they talk about checking up. So it's basically checking up or looking at how the child is doing over time. And we look for evidences if any new learning issues come up, any difficulties come up, which are emerging, so that we can take care of them, raise those flags and work appropriately for the overall development of the child. And also, I would like to add on here that assessment and monitoring progress is not a one-time thing. It is kind of, I would say, a never-ending thing, and we look at the long-term outcomes that we get. So with this small introduction, I would like to go on to the specific questions which I would like to address to my panelists. The first question is with respect to the areas or aspects of a comprehensive assessment protocol that we would like to use, or which is important for these children using cochlear implants post-implantation is what we are looking at. And at what post-implant intervals do we feel these areas need to be addressed? So my first question would be to Ms. Prithvi and then to Dr. Ruchika. I would like to have inputs from the two of you. Prithvi, could you please unmute yourself? And
yes, please. Am I audible now?
yes, you are.
Yeah, thank you, Shweta. And first of all, I would like to thank the organizing committee for having me here. Coming to comprehensive assessment post-implantation, there's a lot of areas. It's a multidisciplinary assessment, basically, and involves a lot of team of professionals over here. And first and foremost, when we consider the comprehensive audiological evaluation, the child would have already, got the best technology in place. And now we need to be very cautious if we are using the technology well. And also, we need to get the aided audiogram to check in if the hearing threshold levels are, at par. And the environmental sound recognition test and a few speech recognition tests gives us an idea on the perception of the sound and the quality of the sound that the child is hearing at present with the cochlear implant. And a comprehensive language expressive and language assessment, and the communication evaluation is also required to see, how many words the child is using. Is the child, having using phrases or sentences, or how is the mode of communication? Is it verbal or non-verbal, or they are still using gestures to communicate their basic needs? And the way the child is articulating, the speech sounds, how they are producing it, is it all fine? And the intelligibility can also be looked upon. And even we have to do this psychological evaluation to know about the intellectual level of the child, and what is the level of executive skills in a child. By using developmental profiles, we can even check on child's pre-academic skills, socio-emotional adjustment levels as well. I think it's always better to do an assessment on quality of life to see if there is any changes in the way the child is participating in day-to-day situation. Are they facing any problem, or is there any issue in the social gathering and at school? And the most important aspect is the self-advocacy skill. While most of the parents are, undoubtedly very protective of their children with hearing loss, but parents play a very important role in laying the foundation for these children to be more independent in handling themselves in various situations and to positively advocating themselves at very young age. And I would also suggest, parent-child videotapes in the given period of time. That also will help to get an overview of how the child is progressing. And coming to when should we do the assessment? It can be done every 3 months, the first year, and then we can do it at the interval of 6 months, and or whenever required.
Thank you, Prithvi, for this really collated answer. Dr. Ruchika, would you like to add anything more to it?
Yeah, Prithvi
Yes.
has mostly covered all the aspects, and I will just add 2 points here. That there is a lot of variation since our candidacy is expanding, and since the theme is also redefined and refined and redefined, so we need to see a child. The assessment protocols also sometimes have to be tailor-made. You can't fix one assessment, and that cannot be for everyone. Sometimes you have to tailor-made your assessments. Apart from the basic assessments that we do, auditory, speech and language, reception, pragmatic, social, quality of life, even the pre-literacy skills are also important to assess, because our role doesn't stop after mainstreaming the child. We are there, our role remains much longer. Okay, so we need to assess pre-literacy skills, quality of life, and nowadays we all are aware that they can easily perceive the music also. So we have gone much beyond just helping them to develop the speech and the language skills. And regarding the interval, I would say that it depends. Initially, when it comes to the initially, you will not see much improvement in the speech and the language, and in other areas the progress. So initial assessment is more restricted to the auditory skills, how the child is developing, how is his bonding with the device, is he benefiting or not, and that needs to be assessed, I think, on a monthly basis, because, and whether there is a functional use of the device or not, because if there is a bonding to the device, obviously it will lead to a speech and the language development later on in life. So this is what I just want to add. Otherwise, Prithvi has covered most of the points.
Thank you so much, Dr. Ruchika. Yes, absolutely. We all agree that the comprehensive assessment should look at all the aspects, specifically the listening skills, communication skills, social emotional skills, cognition, pragmatics. We look at music, quality of life. And as you rightly pointed out, as our candidacy is getting redefined, we need to also look at, so you mentioned about pre-literacy skills or academic skills, reading and writing skills, which will be important, especially with respect to when we talk about crossover recipients. And those aspects need to be taken into considerations when you are looking at their post-implant outcomes. And yes, I agree to what you all are saying with respect to post-implant intervals. Initially, it should be more focused on the listening skills specifically, and over a period of time, definitely the other aspects of assessment can be looked at, that is language, speech, and as you go on, as the post-implant intervals increase, or the implant age increases, we could definitely add on more assessments to our protocol as such. Okay, thank you so much. And coming on to the next aspect, or the next question, looking at what areas we are going to assess, what do you feel, or what do you think are the different types of assessment and tools that you would include for monitoring the child's progress after cochlear implantation? I would like you all to give us some examples. And this question I would like to address to Parul first, and then to Ms. Puja. Parul, could you please unmute yourself and give us your views?
Thank you, Sigi, and thank you, Shweta. There are many assessments, as we already talked about in the earlier question that was put on, that we need to definitely not only look at the auditory skills, the language aspects, the cognition. So just to summarize what normally we do, and what are the tests that we do in our daily routine clinics. First, the question says the different types of assessment. So it's basically not just audition. It's besides audition, we look at language, both the receptive and the expressive, the speech production, even the oromotor skills for that matter for the child, because that is a major aspect that we need to consider when we talk about speech production. Then we look at the attention and behavior aspects of the child, the communication intent, the play and the social skills of the child, including besides that, including a number of other aspects like the pragmatics and the syntax at a later age, after a certain after the child has developed enough MLU or the language aspect of, we look into aspects, these aspects also, the syntax and the pragmatics also, even taking into account the music and the quality of life questionnaire, and the parent participation, how well they are at each level with the child. So that, and video analysis, we do it every 3 months, so that we can assess and guide the child later on. We sit with the parents every 3 months and discuss what is it, where is it going wrong, and what we need to further do, so that that becomes a tool in terms of even the parents knowing and even the assessing the therapists who are working with the child. So these are the things that would definitely we look into. Now talking about what tools we use for assessment. So it's not like basic one part that I would make it very clear. It's the scales that we use for assessment should be different from the ones that we use for therapy. You know, our plans should be such that the goals that we make shouldn't be the ones that we need that we take for assessment later on. For example, if I'm taking the integrated scales of development for assessment, I wouldn't use the same scale for assessing language when I'm assessing the child after 3 months or 6 months, whatsoever, whenever we are doing the assessment. So that's a major concern that we need to look into. Otherwise, you would just take in that goals and you would assess the child on that and you feel that your goals are achieved. So this is one major thing that I see many of them doing, and I've seen at many of the clinics. So this is what I would suggest. We look into first when a child comes to us, we take into consideration the chip, the child hearing implant profile. We do the assessments based on that. Our plans are designed based on the OS plan that we generally follow. And when we look at the tools that we use for assessment, so we use it's not like just restrict ourselves to CAP and SIR that had been, we have been doing for so many years earlier. So it's like IT MACE, moves for the auditory skills with very simple tests to go on with the clinic, and it can be administered also at when there is a lot of patients also. It doesn't take much long once you have hands over it. For language, we use the reels or we use the 3D LAT and for the receptivity for cognition and other assessments, and for that we even use the ComDeal and the St. Gabriel's curriculum for that matter. Looking at the other aspects like the speech production, we use the photo articulation test for that generally, or the Hindi version and the Gujarati we have made it for our clinic. So because we have more of Gujarati patients at our end, so we have modified it slightly from our aspect. So that is what we look into. So this is what I think in brief. I can just consider that we do generally at regular intervals at our clinic.
Thank you, Parul, for your input. Here specifically, as you spoke about the type of assessment which you spoke, and you said about video analysis, which is like an informal way of assessment. Puja, I would like you to focus on a few of the types, as in the standardized assessment or the norm referenced, or what we call as criteria reference type of assessment, or the scales that we use, or the profiles. Could you please or put some light or throw some light on this aspect? Which ones would we be using, and why certain types of tests cannot be applicable in our Indian scenario?
Sure. Thank you, organizers, for having me. So I just want to say that there can be 3 types of assessment if I would like to bifurcate them into. So one would be formal assessment, wherein you are using a particular tool to test a particular domain, say audition, speech, language, or other such domains. And then these are mostly, since they are time consuming and they have rules, these could be done like once a year. And then you could use tools to test audition, like the ears test battery can be used to be testing language, either linguistic profile test or Kannada language test or other such language test in various languages. Those can be used to be testing articulation. One could use the articulation tests available in various Indian languages that we have. And then similarly, you could use many of such tests. I just wanted to cover a bit on informal assessment as well. So we say that informal assessment, in the absence of standardized tool, we could do it. So again, when we are doing informal assessment, there can be like various types. One is spontaneous language sampling, or then we could use checklist and scales, or we could use profiling. But and then we are using tools like the MacArthur-Bates communication inventory, which is primarily in English, but then they have made an attempt to make the word list of that particular inventory available in various Indian languages as well. So what we need to do is we need to do those tests in our clinics and then build a database around that. So we can build norms around that. So we have the tools. All we have to do is just to use them and then make norms on them. And then if, say, for example, the child is very young, like lesser than 30 months or lesser than, I would say, 2.5 years, and then the child doesn't have pointing abilities, or the child doesn't have, let's say, verbal abilities, then we might want to use play-based methods, or we might want to rely on parental reports. And in such a case, we can use questionnaires like the Little Ears Auditory Questionnaire, or we can use criterion reference tools like the Auditory Skills Checklist, and then we can observe the child while the child is doing something, and then we can mark the goals there. So that's what I wanted to say.
Thank you, Puja, for that precise information. So using informal tools as well as formal tests, and also looking at norms or collecting norms for our population so that we can use more and more tests, and which can give us basically the time frame or the outcomes. And looking at that, we can plan our intervention accordingly. Thank you so much. Moving on to the next question. As Parul mentioned, and that was my next question, which I was going to focus on, as she clearly said that defining between tools that are used for assessment and those that are used for goal planning, here is something which we generally have a confusion in, and this definitely leads to a practice effect, what difference we see in our outcomes. So why exactly do we need to clearly define? I would like to put this question to Dr. Rupali Mathur. Can you please focus on why we clearly need to define between the tools used?
Yeah. So first and foremost, I want to tell, when we are using the assessment tool, there are various tools. So to effectively use the assessment tool and interpret them, we should first know what is the purpose of the test. That is very important. Purpose and which areas they are covering. Okay, which skill they are covering. So there are various skills. So we have to see what skill they are covering. So here, when we have to see, there are various. Initially, Shweta told what is the main aim of assessment: to find out the ability, what the child is able to do, to monitor the progress. But what is the main aim of goal setting? When you're doing a goal setting, what test you're using it? The main aim is to guide and give us direction, which area we can progress. So which can help us to evaluate the performance and to control how we should move on in which area. So that is the main aim of goal setting. So when we are doing assessment overall, we need to use many formal and informal tools, which already previously told. Like formal tools, we can use norm reference test, which is usually when we are seeing comparison with the normal group. So how we are doing in comparison to normal group, they are normal or they are deviant or they are behind. So we can find out that. And then their criterion reference test, which they know different ability, how they are doing it. Okay. But when you're using the test, like different goal test for goal setting, you usually use the goal set, like maybe some criterion reference test, or maybe some like OS plan you can use. So those are very different and it gives very different input. Okay. So that's what I wanted to tell.
Thank you, Rupali. So basically you're saying some kind of training manuals should be used for goal planning, so that we can actually look at which are the areas or aspects which the child faces a problem in, which we can work on. And there should be a clear definition between the tools which are used for assessment, because those can never be used for goal planning. And when you are looking at standardized tests, you say, or you feel that norm reference tests could be used in order to know which areas, what are the strengths in those specific areas.
Yeah, and the norm reference test we cannot use to monitor the progress. It is very difficult. We just can compare with the child, like other normals. Okay. So to monitor the over a time period, we should use a criterion reference, and that will help in the goal setting.
So looking at the developmental level of the child, so it will help you in. Okay, thank you. Puja, any inputs more on this, or do you?
No, I just wanted to say one more thing, like when we are using a particular manual to set goals, here it is more child specific. So when we are using this particular thing to assess, we will see how well the child has achieved this particular goal. and it is very, very child specific. But like Rupali said, when we are using an assessment tool, we are comparing the child with typically developing children of his or her chronological age, and also other children of his or her hearing age. So I would say that we must not be using goal setting tools to be assessing children to see how good or how bad they are performing. Goal setting things are for setting goals and to see whether the child is making a progress in the session or not. Whereas if you want to see if overall the child is progressing or not within a particular stipulated time, then we might want to use proper assessment tools.
Okay, so you mean to say it is more like an formative assessment. When it becomes child specific, you want to see how the child is developing over time. With the learning aspect that we look at, you would go more towards a formative assessment. Thank you so much. With this, we come on to the next question, which I feel will give in some more inputs. We already had a panel on this, but specifically to look at when you are assessing children with additional needs, do you feel formative type of assessment, which I just spoke about, is appropriate for monitoring progress? And what more do you like to add to this aspect? This question I would like to address to Ruchika first. Dr. Ruchika, can you please give your inputs on this?
There are no standardized tests or the norms available to assess these children. They are unique. They are every child with special or additional needs is unique. As you rightly said when you were starting this panel, that this assessment is not to take out the faults, that this is what you are not, their failures, that this is not, you are not able to achieve, this is what. So this population needs to be, taken care very, very carefully. At present, as per my knowledge, we do not have any standardized test. And in the morning panel also, somebody pointed out that there are so many variations in this population. So we need to do many informal ways of assessments. Okay.
Would you like to point out which specific informal assessments would you like to do? Like, for example, I think in the earlier question, one of you all pointed out that video analysis can be helpful.
Yes.
Something else.
In this, we usually assess them informally, and then we compare with the timelines that are given in OS plan. That is the OS plan very easily explains it, categorize the children during the assessment. Initially, group A, group B, group C, and group D. Group A is the one which is likely to benefit more from the cochlear implant. Early implanted, early intervene, family support, all the positive factors are there. Group B is the one late identified and late intervened, and group C and D are with those with the special needs. So we do the informal assessments and then compare with the timelines that are given in the OS plan for the group C and the group D.
Okay, so you would like to go ahead with the auditory speech language manual, which is for professionals, which is given by Mary Kay Therese and Adeline McClatchy, if I'm not wrong.
Yes. That is
okay, so you would look at that with respect to the timelines. Rupali, can you add on what more with respect to informal tests would you do, or informal observation, or what would you like to add on to this?
So what I feel is like we are doing informal assessment, so we can take more of the parents' input, what they feel. That is very important, because sometimes what happens when they have multiple needs, maybe the child is not doing what difficulty they are facing at home. So the parental input will give us a lot of very helpful. And then we have to see like what complex need they have. So like if they have difficulty in vision, so accordingly, if we are showing them something, so we need to modify our test material if we are using some test material. So if somebody has a locomotor disability, so how we should modify and how we should interpret the result. So like if they question in the reels or SCCS, if we ask something, the child should get it from the other room. So we should interpret in that way how the child can do. If he has CP, so if he cannot hold the things and if he cannot select, so how we should see the eye gaze movement, how we can interpret the result. So like that, depending on the different disability, it should be tailor-made. So what test we need to use, and informal and some formal assessment tools also with the modification of the tests, what I feel is.
Okay, thank you, Rupali. I think Dr. Ruchika, you had to add something.
Yeah, and the one more point that, we focus more on the quality of life for these when we were doing the assessment, and their assessment is not on a monthly or a 3-monthly basis. It is, I feel that it is little delayed. It is we should do 6 monthly assessments for them, because they do not make a very fast progress. And it is very disheartening because the parents know what you are doing, you are assessing, and then they will ask you the results also. So I feel that their assessment period is also a little longer as compared to the other implantees.
So to add on, as you said, that it should be a formative type of assessment, and it should be tailor-made, specific. Their progress intervals, or when we need to monitor their progress, it should be after or biannually, after 6 months or so. And an informal type of assessment with respect to video analysis or observation or diary logging the questions would be helpful to know specifically what behaviors have changed in the child, because each and every small aspect which has improved needs to be added on as a progress in these children. Thank you so much. So going on to the next question, which I would like to put forth to Puja and Parul. How do you think assessment for older pre-lingual children using cochlear implants is different from the younger age group? So we know most of our children who are implanted below 3 and above 3, or if you look at the age group of 4 and above or 5 and above. So do you think these scales that we use could be appropriate for these older pre-lingual children using cochlear implants who are implanted late? Puja, could you please throw some light on this?
Yeah, I would say that each test that we use is for a particular population. Say, for example, the Little Ears Auditory Questionnaire, it is majorly meant for babies and toddlers, like those who are lesser than 2. Similarly, if I were to test a child who is 5 and then I wanted to use the Little Ears Auditory Questionnaire on that, then the 5-year-old will obviously surpass it, because the child has already acquired some of the skills because of the cognitive advancement that the child has before the implantation process. So I would say that we should stick to like either using criterion reference tools like the auditory skills checklist if you do not have tools for measuring particular age group, or we should stick to using tools meant for a particular age group only.
Thank you so much, Puja. Parul, would you like to add something more?
I agree to what Puja says, but just a couple of things that I would like to add here is older pre-lingual children, when they come to us, we definitely look into even the vocab aspect in that manner. Because the thing is, even the speech production skills, is there any such issues that is, not helping them out to have proper speech, the articulation aspect? That is one thing that I would like to add, because there could be at times apraxia or something that we might miss out. So this is what I would like to add along to it.
Okay, so basically looking at their cognitive level, you could add on, or what you all are suggesting is we should add on some non-verbal language tests, plus you look at their oromotor skills also, their speech production skills also, in order to look at how their communication aspects are. Plus, communication should be looked at from both the angles, not only from a verbal spoken language form, it should also be from a non-verbal mode of aspect, which we need to assess. Okay, thank you on this. And coming on to the next question, which is something which we often see even in our younger group, that is, how do we interpret the language gap that is observed during repeated assessments. Now, I think we have heard a lot about this language gap, wherein we say that after 1 year of implantation, there needs to be like a 6 months or there is a 6 months language gap present, or within 3 years, this gap needs to be, completely covered up, and these children need to be performing like their typically developing peers. But majority of our children that we see are in the 3 to 5 or 6 age range. So when we look at that language gap, do you feel that this gap is necessary to be observed? How much of a gap is okay? Or what would you actually identify as a significant language gap? So could Rupali, do you want to throw some light on this? And then I would go to Dr. Ruchika for your comments.
Okay, so I think before like language gap, first we should know the hearing age of the child. That also matters a lot. So we have to correlate both the things. What is the hearing age and the language gap? So if the hearing age of the child is maybe 2 years and language gap is maybe he's now 5-year-old, but he got implanted at he was 3-year-old, so he is behind 2 years. So if we see in the following outcome measurement progress monitoring, we see the child is lagging behind more. So like the gap is more than 2 years, so then we should see what are the factors which are hindering the progress of the child. So it should not be more. I think the main aim is we should reduce the gap, but at least it should not increase more when the child is growing further. Okay, so that is the main thing we should look on in from an Indian perspective, because when you see the Western scenario, or if the child is getting implanted at like 1 year or younger than that, then there is usually no language gap is seen. But we have to consider our scenario, and then we have to see how much the child is coming to the clinic. So we should see whether the therapy, he is attending therapy, the home training, how adequate is the home training, how are the parents working at home, or if there's any diagnosis which we are missing, if he has some additional problem, like maybe he has some behavioral problem which we are not able to identify the child is having the behavioral problem, or any other attention deficits are there, so we need to like enroll the child for other therapies also, so that he can cover on these areas.
Okay, so what you want to say is you look at the hearing age of the child, and the language gap most often needs to be narrowed down, but it should not increase, so that we know that we are getting some progress, or we are getting some outcomes with the child. Okay, that's a good point. Dr. Ruchika, would you like to add on something to this?
There is no doubt that the language gap will be there in the late implantees, but we should monitor the gap. The gap should, if the gap is remaining static or if it is increasing, both are the worries. Then, as Rupali correctly mentioned, that we need to assess, where sometimes these late implantees are very stubborn. They have emotional issues, and we have to look into that. Hearing aid, she correctly pointed out. Family support, she correctly pointed out. And other additional problems if they have. So we have to accept that the language gap will be there, but the language assessment has to be not only verbal language, speech, it has to be non-verbal language also. The assessment should include the non-verbal language also. The worry will come when it is the language gap is remaining static or it is increasing. And when it is happening, then we need to assess further that where are the areas, and we try to work on those areas also.
Okay.
And so, sometimes,
Yes, continue, Dr. Ruchika.
And sometimes in these late implantees, we, depending upon this gap, we might have to change our approach of therapy from going to auditory oral to total communication also sometimes.
Okay, so here basically you want to point out that the choice of communication modality can change when you see that the language gap over time is being static, or it could be increasing, which is pointing to some kind of difficulty. Probably which factor is exactly being responsible, we might not be able to exactly point down, but it is an indicator that the child is having some other needs and we need to address it. Thank you so much. Going on to the next question with respect to long-term outcomes when we talk about, and we have seen this most often in our clinical practice, is that when children come back to us and their parents ask us, when they are really older in age and they come back to us and the parents ask us, I really want y'all to check how the child is doing with respect to academics. And here is where we are exactly lost, because we don't have any standardized tests in our scenario. So how would you actually look at if the child is progressing well in academics? What would you like to do in order to know and at least discuss these results, whatever the interpretation you get, with the parents, so that they have this, whatever their concerns are, can be addressed to properly or appropriately? I think, Puja, would you like to address this question?
Yeah, sure. So when assessing a child who has been implanted for quite some time, I would like to do an assessment of two aspects. One is the linguistic aspects, and one more is the academic or the educational aspects. So when it comes to linguistics aspect, if the child is, say, below 8 years old, then in India we have the LPT or other tools that we can use to assess and see how good the child is faring. For academic things, we have the ERS, or we have the PADIC developed by Aish that can be used to see how good or bad the child is faring in classroom. But say, for example, this child has graduated from that 8-year to like 9-year-old to being a teen now, and then in Indian languages we do not have a test. What I would like to do is, I might want to take a spontaneous language sample from the child and then try to break it down and see what kind of sentences the child is using, what kind of grammatical markers the child is using. Is the child able to use all the 8 functions of language? Like, is he using self-reporting, projecting, self-advocacy kind of sentences, all those things? And then is the child, if the child is in school, so the child will need to be able to use things like defining a particular thing. So I might want to also use the 5B portion of the OS plan, wherein I would see if the child is able to do all those higher level audition skills, which should support the cognitive academic language that the child would need in to fare well in school. So.
Thank you, Puja. It was very crisp and to the point with respect to linguistic and educational aspects. So you're focusing more on reading, writing skills through language sampling, which is a perfect way to assess these children's, the elder kids or the teenagers, which is a very nice thing. And also you mentioned about the tools, that is the language profile test, which are available in Indian languages, which we could look at and use for our assessments. Coming on to our last question, while formulating best practice guidelines, what do all of you all feel an ideal assessment protocol should include? I would like each one of you to put forth your points with respect to when we look at a protocol or a best practice guideline, which we could give as a summary to everyone with looking at the assessment and monitoring their progress. Rupali, can we start with you?
Yes. Actually, before that, I want to answer that previous question also for academic. When we are assessing the academics, I think you should assess the phonological awareness skills also. That is very important. And other thing is, we should collaborate with the teacher, the general education teacher, to see how the child is performing at school. That is very important thing. We should contact them also, and we should see how the child is doing as per her peer group. So that is very important thing. We should do it, I feel. Coming on to this thing. So what I feel is, for the ideal assessment protocol, it should be a comprehensive test. So if you see a classification by ICF, International Classification of Functioning Disability Health, which is given by WHO, which say when we are assessing a child, we should not see only what is the child's ability. We should see the environment also, how he is participating in the environment. So what is the factors? So we should consider everything, a child as a whole thing. So like we should consider like speech perception skill, that is auditory skill, speech, which everybody told, the language area, different language area, like language is very vast. So some tests cover like semantics and syntax when we see LPT and all. So we should cover the pragmatic part also, which usually remains untapped. So that is very important thing. And then voice, how is the voice quality? That also we should see, because many a time when the child comes, they have the, like parents say that voice is sounding different, because usually in the late implanty, that is very important thing. So we should do that also in the assessment thing. And then cognition, which everybody has told initially, then music ability and their play ability. The play, how is their play? The play assessment of play skills is also very important. We should do it. And then literacy part, and then quality of life, which is like how they are doing at the in the environment. The other important thing is, when we should do assessment, there should be different kind of assessment. Like one, we do the baseline assessment or candidacy assessment. And then after the implant, when we do a baseline assessment and then the progress, so everything is changed. So baseline assessment should include like everything, we have formal and informal, like norm reference and criterion reference test. But when we are doing the progress, like after 3 months, 6 months, 12 months, that time we can do different criterion reference tests, which are easy to do. And maybe yearly once we can do a detailed assessment, which include the ROM reference test like LPT and all, because it takes a lot of time. So those we can do at least yearly, and other criterion reference tests we should do at a regular interval.
Thank you, Rupali. I would like the other panelists, in short, if there is anything else to be added, but I want each one of you to talk. So Parul, could you please highlight anything else or a specific thing?
Yeah, just a couple of things, the quality of life and the music aspect. I think even we can put into consideration, because it's not like just speech, language and everything. Even music is a part of everyone's life. So why not, why bar these children too? So we look into even that aspect and the quality of life.
Thank you. Prudhwai, can you please add on anything else that you would like to?
Yeah, already Dr. Ruchika was mentioning it should be tailor-made. We cannot, have a generalized set of batteries or tools saying that these are the things that we need to cover up when we sit with a child for an assessment. So it should vary depending on the needs of the child and the need of the environment that the child is living in.
Thank you.
And one more thing that I would like to add in is counseling and educating the parents before the assessment or after the assessment.
Okay, thank you. So providing a feedback.
That is also very crucial, because most of the parents and the kids, they get anxious when you sit for an assessment.
Correct. Thank you so much. Ruchika, would you like to add something?
Yes, everybody added with the best practice guidelines with the normal kids. So I would add with the complex or the additional needs children. With them, not only the assessment protocol should we should document the assessments from the other professionals also, like what they are doing in the sensory integration classes, how much progress they are making in the physiotherapy, and maybe their occupational therapy. So all these things are to be documented. This is also a progress. So all these things should be a part of an assessment protocol when you are dealing with the children with complex or additional needs. And the second that I would like is how well, pragmatics, how well they are using the language and how they are adapting socially in the environment. It is very important to make these children confident. So whether are they able to make friends or not, how they are performing socially, I think this is a very important aspect that we need to take care when we are doing the assessments.
Thank you, Dr. Ruchika. Puja, anything else? I think almost all the points are.
Yeah, everything is covered. I just want to say that periodically we must be using something like a developmental screener, which has multiple domains, so that we can see the child holistically. Like the child's journey is there, which assesses the child on audition, language, speech, pragmatics, theory of mind, literacy and play. Along with this, I also wanted to add that we have been talking about assessing the child, but what about assessing the parent and the family? So I feel that we must be using some tools like working with young children with CI by Julie Kosaner. That has a beautiful form to assess the skills of the parents. Or one could use the parent guidance form by Dr. Murag Clark, wherein they can see how well the parent is picking up from what you're coaching the parent. Or if you want to see how well the family is interacting with the child, then you could use the family interaction rating scale that's present in the Little Years Diary of Medell. So we must be using all these things for the parent and the family as well.
Thank you, Puja. It's a best, or I would say appropriate point, that to assess the parents' outcome or the family outcomes also. So with this, I would like to summarize with respect to assessment and monitoring progress, as all of you all have compiled it into one. Use of summative and formative assessments for children. Specifically, you can make it, it should be tailor-made. Looking at the areas all of you all correctly pointed out: listening skills, language abilities, social communication, that is pragmatics, speech production, wherein definitely you have to include the voice quality, music, early literacy skills, including the phonological as well as the phonemic awareness, and the reading, writing skills when it comes to academics, also including quality of life, not only of children, but I would say also add on to quality of life of parents, how it has, or the family, how it has changed over time. And from the other domains, we would definitely like to have cognitive, social, emotional aspects which can be checked, and as some of you all pointed out, sensory processing skills, and thus address the child as a whole. And finally, the types of assessments which are used, that is the standardized, norm referenced, criteria reference, which ones to be used when with respect to formal and informal assessments, use of profiles, checklists. So this is like a comprehensive or a battery of tests which you can use with aspect to formal and informal tools, and make a comprehensive or a collaborative assessment, including each and every analysis in detail. Thus, the best practice guidelines will help us to explore the child's areas of strength and work on these areas of difficulties, which gives us a roadmap in order to look at which aspects we need to look at. And mind you, there are many areas which we can work on. It's not that therapy is ended and it's over and the child can go off now. Providing feedback to the parents, as one of you correctly pointed out, on the interpretation of the comprehensive assessments, identifying which targets you need to work on, and planning a SMART, that is specific, measurable, achievable, reliable, and time-bound intervention to narrow the gap. And an interactive nature of assessment and monitoring progress would definitely help us to go or look forward to a positive outcome in these children using cochlear implants. Ruchika, you had to add something because I'm just ending it.
I just want to add that during my PhD, I had developed a comprehensive test. It is in the form of a parent questionnaire, and it is in Hindi language, and it is available if anybody wants. Then it's a platform where many people are listening to us. It is a parent questionnaire, and it completely assesses all the major areas of a cochlear implant recipient. So if anybody needs the details about it, can refer to me. I can give the details on it. It is in Hindi language.
Thank you so much, Ruchika. Thank you. I think your email details probably could be shared so that everyone can get access to it. Thank you very much. And Rashmi, I would like to forward it to you now for ending this session.
Thank you so much. It was a very comprehensive discussion, and I have to congratulate you for keeping to time, and we finished actually bang on time. That's really amazing. So thank you for keeping to time. I think they're very valid points made, and we all know that there is a need for having a best practices or a good clinical practice. And I think assessment is something that we all feel the need that we need to discuss more. I hope this platform at least gives us maybe we can get together again and we need to discuss, and maybe at some point of time we can come up with some sort of protocol, hopefully. So maybe some sort of multicentric study or multicentric, I think we need to have discussions. So thank you to all the panelists, and thank you to you. I think all the panelists are so good at what they do that everybody's opinion was really important, and that will be really great that everybody can listen on to and get a lot of experience and knowledge. So thank you so much for your time. And thank you to all the panelists too.
Yes, thank you from my side too to all the panelists for giving your time and such valuable inputs for making this a success. Thank you.
Thank you.
Thank
Yeah,
you.
thank you.
Thank you.
Group photograph.
Bye.
Thank you.
Thank you. Bye.
Can we have a group photograph before we leave? Shweta left.
I'm
Oh,
there.
Shweta. Can we have a group photograph if, or I'll have it and then I'll share it in the group.
We are still live. It's
I've
not
just done
stopped,
it.
okay?
Thank you.
Thank you.
Good evening, Vahishtai.
Good evening.
Hi.
Hi.
So after that panel discussion, we now have an invited lecture supporting higher order thinking skills and executive functioning in children with cochlear implants. This is by Miss Amy McConkey Robbins from the US. I'll be now introducing our chairperson, Ms. Vahishtai Dapu. So Ms. Vahishtai Dabu, who's from India, is a LSLS certified AVT and a certified mental health practitioner. She's the principal consultant of integrated services for listening and spoken language. She consults with companies, organizations, hospitals, mentors, professionals, and builds capacity by conducting training. She also continues to work with children and adults with cochlear implants. She's the managing trustee of We Connect Foundation, a parent support group, and we all are aware of the work she's been doing through this foundation. She serves on the board of the Alexander Graham Bell Academy, US, on the Listening and Spoken Language Certification Committee. And she's the co-founder and trainer at Online AVT, conducting AVT courses for professionals. So Vaishtai, I invite you. And we just had one thing to say about this. So since Amy is from the US and the timings weren't really convenient for her to come live and give this presentation, she very kindly has sent us her presentation. It's a recorded presentation. In the presentation, it is actually not on the slideshow mode. So hence we do regret to say that we'll not be able to change that since it's a recording. So thank you for adjusting. Vaishtai, I give the floor to you and you can now introduce Ms. Amy McConkey Robbins and then we can start her presentation.
Sure. Thank you so much, Rashmi. So Ms. Amy McConkey Robbins is an MS, CCSLP, LSLS Cert AVT, an AVT and SLP in Indianapolis. Amy is the author of Maze and IT Maze, Common Phrases Task and Mr. Potato Head Task, Red Flags Procedure, Tune-Ups, and Bilingual Family Interview or BIFI. She lectures internationally on children with hearing technologies and on preventing burnout for those in serving professions. Ms. Robbins has published over 100 articles or chapters in professional journals and textbooks. She serves on the board of directors of the American Cochlear Implant Alliance and was a co-author of ACIA's position paper on habilitation guidelines for children with cochlear implants. In 2013, Indiana's governor appointed her board of director vice president of Healthy Hosiers Foundation. Amy received the Richard Miyamoto Award for LSLS service and was named a distinguished alumna of Purdue University. So, welcome to Amy McConkey Robbins, and we all look forward to hearing a wonderful lecture by her.
Can we start sharing her presentation?
Yes, please.
Hello, I'm Amy McConkey Robbins, and I am so pleased to be here with you to talk about a topic that's of great interest to me, and I hope to you too. And that is how we support higher order thinking skills, or HOTS, and executive functioning in our children, our patients with cochlear implants, by using what I call bossing your brain techniques. Now, the term boss your brain was initially coined by a wonderful woman named Patricia Lindemood of the Lindemood Bell fame. She and I were at a meeting together, and I asked Pat if I could borrow her term, boss your brain, which was kind of buried in her work, to use specifically in my work in publications for children with hearing loss. And she said, absolutely. So I like to credit Pat when I use this term. Bossing your brain is the way we help children understand that you can make your brain think in a new way. You can actually help your brain be smarter, learn better, be more organized, be less impulsive. But like anything else you want to do and improve on, whether it's sports or playing a musical instrument, you have to practice. And you have to be an active participant. You have to be the boss of your brain. I've outlined in a number of publications some more specifics about boss your brain techniques, but let me just review a few here, and then we're going to talk more about some of them, and you'll see them on video clips too. One of the strategies that's so important for our deaf and hard of hearing children is reauditorization, which just means talking out loud. You're really thinking out loud is what you're doing. We reauditorize when we talk to ourselves or concentrate things to ourselves. We use an important cue, which is called finger cues. And that's because these are the world's best memory aids. You'll never forget them. You'll never leave them in your backpack. You'll never wonder where they are. And they serve many different purposes, particularly when we're trying to mark items for motor rehearsal tasks. And we will, not motor rehearsal, for working memory. For working memory tasks. And we're going to talk about examples there. Motor rehearsal means to act something out. And that helps your body prime or get ready to connect information about that action. Visualization is when we picture something or image it. Categorization is trying to organize by looking in the right file folder and accessing information and connecting it to similar things, as we do when we file papers or we put files on our computer and folders. Using music is an important boss your brain cue because music is our memory magnet. Things we learn musically, we almost never forget. So we use elements like rhythm and melody and body movement. Association, Invisible Blackboard, and placing information in a larger context are all additional boss your brain strategies that we work on with children. Why would you use boss your brain strategies with a student who has cochlear implants? If your patient is disorganized, for example, in their language. They're not able to explain things in sequence. When they talk about something you can't really understand because they're jumping around in time. If they struggle to see the importance of themes that run across different subjects, certainly if they have working memory deficits, which many of our children with hearing loss and cochlear implants have, if they're kids who can't really state the main idea versus the individual items in material that they're listening to or studying, all of these indicate that executive functions are delayed and immature, and that Boss Your Brain is going to be a good way for the student to improve. So speaking of executive functions, just to review, executive functions are fundamental brain-based skills that we need in order to do things like get organized, to plan, to start a job, and then to stay on task and to complete the job, to control our impulses, to regulate our emotions, to be adaptable and resilient, or what is called grit. So when you hear that, you think, well, executive functions then are just about everything that a child needs in order to make his way through a successful childhood. They need these things at home, in school, with friends, and throughout social situations. And I'm going to tell you that my kind of Bible for looking at executive functions, both how to describe them and understand them, but also wonderful suggestions for professionals and parents, is this book, Smart But Scattered. I highly recommend it. Parents find it extremely useful, and I use many of the suggestions that Dawson and Gar put forward. They also have an additional volume called Smart But Scattered Teens, and that's for older children and is also excellent. So what do we know about executive function skills in children with cochlear implants? Well, one of the largest databases, I'm happy to say, is at my home University of Indiana, and Dr. William Cronenberger has at his disposal an enormous archive of data about executive functioning in children with cochlear implants. So he and I are colleagues and co-authors on a lot of things, and I cherish his expertise. And these are some of the things that his research shows. We know that executive functions are underdeveloped in many children who have cochlear implants. About half of the children in total show executive function delays. That's alarming. And shows that we need to be working in this area. But the other thing is, it's actually good news in that half of our kids with cochlear implants don't have executive function disorder or delay. So it's important to distinguish those who are impaired versus those who are not. Executive functions are not the same as language, but they're certainly affected by the language deficits that are very common in our children with hearing loss and cochlear implants. And one of the things we know is that language is a powerful tool to support executive functions and vice versa. Executive functions are critical for academic success and real life situations, and all the way into, across the span of life, into adulthood. We need executive functions. You and I need them to go about our daily lives and accomplish our goals and to be happy. And so what's encouraging is that we can practice explicit techniques that will help executive functions improve. We can get better at EF by using Boss Your Brain techniques. And I think that is very encouraging. So I want to look specifically at some of these Boss Your Brain techniques that I've mentioned. And the first one, and the sort of classic one that I think every student should utilize, your patience. I call my little subjects students or patients, and those words are synonymous for different reasons in my practice in the United States. So I am a speech language pathologist and a LISL Cert AVT. And when I use one word, I'm I'm meaning all of the terms that apply to young children whom I am seeing therapeutically. So reauditorization, as I said, is talking to ourselves, not just to do the action, but because that allows our brain to hear ourselves think. I say this to most of my patients almost every session. You need to reauditorize. Why? So that my brain can hear myself think. Very good. We actually talk about these strategies, we name them, and we talk about why they help. This is not a mystery thing. These techniques are not something shrouded where the child doesn't really understand them. We're very transparent about it. It's a very positive sign in a child with hearing loss if we see that they're reauditorizing, because it doesn't help to reauditorize unless you have strong spoken language auditory-based skills. So if you see a child reauditorizing, this is a moment to really lift it up to parents and to congratulate the child and the parent on the fact that the child is using his spoken language and thinking skills. You got to model this hundreds of times, not just this technique, but all of them. Model, parent model and clinician models in order for children to become successful using these strategies. I'm going to show you a video here of a young child. She has been working on phonics, and we're going to emphasize her speaking out loud, reauditorizing, as she practices inserting different sounds, what we call letter encoding, in order to make nonsense syllables.
Fike, fike, fike. Maybe I should name a baby Fike. Is that a good name? No. Fike. If that says no. You can change that to Mike. Oh, how would we change that to Mike? Get A-M. A-M? Just A-M. Get N-M. Get N-M. Okay. And the E says the I's name. The I's name. The E doesn't say the I's name. The E makes the I say its name. Yes. Mike. Mike. And if that says Mike, this says Vike. Sorry? Vike. Perfect. And if that says Vike, this says Voke. Voke.
So reauditorization is important whether you're doing a number of different tasks. In that case, as I said, it was an analytic reading task. It helps her so much to hear herself produce these sounds and to always say them out loud. Finger cues are another really helpful boss your brain cue, because they mark bits of information and they remind us how many bits we have to remember, right? Because it's 1 bit per finger. And they help us sequence the bits too. So let's say I use finger cues all the time. I'm on my way to the grocery store. My husband says, oh, by the way, we need milk, eggs, and bread. And I think, okay, and I reauditorize and use finger cues. And by the way, we often use multiple boss your brain cues simultaneously. So I say, okay, eggs, milk, bread. 3 things. So I know I have 3 things. I've marked them on my fingers, and I get to the grocery store and I say, oh gosh, what did he tell me to get? Well, yeah, I'm pretty sure there were 3. I remember marking 3 things. So we had milk and we had eggs and we had bread. Okay. I said them out loud. I used my finger cues. One of my students said, Miss Amy, I call this the golf clues. I said, golf clues, why? I said, because these are like the flags on a golf course that mark where you want the ball to go. It kind of draws your attention to them. And I said, fabulous. I like your name. We're going to, for when you work with this strategy, we're going to call it your golf flag strategy. And that's just fine. When kids own these strategies, that means that they're going to incorporate them. And that's what we want, isn't it? That's the goal. motor rehearsal or acting it out is a very important strategy. When we act something out, we actually stimulate the parts of our brain that read as us doing the action. Here's an example. If you see an Olympic gymnast who's getting ready to go out and do her floor routine, you will see her on the side of the big arena doing this. Okay, she's using two different Boshu brain strategies. She is visualizing herself going through the routine, and she is doing motor rehearsal. She's actually acting out the routine. She's moving her body. Of course, she's not actually flipping or actually standing on her head, but she's visualizing herself doing that. And motor rehearsal can be a really great activity strategy depending on what task we're working on. And that's true of all the Boshu brain strategies. You have to pick the one that actually fits the task that is at hand. One of the acted out strategies is the invisible blackboard, which is a Lindemood Bell technique. It's another thing that's so handy because everybody has an invisible blackboard. It's right here. You might want to do this right now. It's just right in front of your visual field. It's about this big. When we write on our blackboard, we are actually forming a strong image and a strong motor pattern for what we have written, either with letters or if we do math on our invisible blackboard. This is part of the see, say, and write technique that is advocated and written about for the Lindemood Bell technique. And it's something I find very helpful for children. As I said, we can do it with either spelling and written words, or we can do it with math. And that's what this patient of mine is going to be doing right now. He's going to be doing an auditory and executive function Boshu brain game called Add One Each.
So add one to each, but wait till they're all done before you answer them. You can be using a strategy while I say them. Okay. 1, 3, 4. 2, 4, 5. What strategies were you using?
The invisible blackboard.
Wow. Doesn't that help you?
It does. It's a good one.
See, and you know that by writing it out, you were also using the motor acted out strategy. All right, Cooper, you're going to do a few and then you're going to give some to me.
Ooh, you're going to see if I can remember use a strategy.
Ready?
Wait, we do it backwards?
Not backwards, no. Remember, Mom had 1, 3, 4, and she had to add 1 each. So 1 plus 1 is 2, then 3 plus 1 is 4. Yeah. Yeah. Okay,
You ready? Got your strategy all picked out?
7, 9, 1.
Eight, 10, 2.
Beautiful. 1, 2, 6.
2, 3, 7.
May I ask you a question? When you're writing on the blackboard, are you writing the number that I say, or are you already adding 1 to it and writing that?
I'm already adding 1 to it.
You're doing the math in your head and then writing it down. Was that what you were doing, Mom?
No, I needed to write mine down first and then go back and add.
So that just shows you can use a strategy different ways depending on what the learner needs. That was good that you adapted it to what you needed, Cooper. I'm going to try to.
I think that's an interesting point, that we use strategies in a way that is most helpful to us. Mom was using the strategy slightly different, writing the numbers that I said on her board and then doing the math. Cooper was listening to the number and already adding 1 to it and then writing the answer down on his invisible blackboard. I think you might have noticed he has bilateral cochlear implants. You couldn't see the other side of his head. He came to his family through adoption and didn't receive his cochlear implants until he was almost 2 for the first one, and then shortly thereafter for the second one. And he has just made wonderful spoken language and listening progress and academic progress. So visualizing is a powerful tool that we have. Visualizing means that we can image something in our brain that's related to what we have heard or what we have read. And the Linda Mood Bell folks have really championed a program called Visualizing Verbalizing that talks about the fact that the best way to retain linguistic information is to form a mental image of it. We don't remember the book Moby Dick, but we can remember images from the book that we read, right? So images are a powerful memory tool. And what they found is that people who are the most successful readers or the most successful listeners as students actually form movies in their mind. They see moving images that relate to information that they know or that they have learned. And visualizing is one of those things that is part of how we relate to other people. It's a way that we can relate to characters in a book that we're reading, to go beyond decoding or word by word comprehension, but to understand characters, right? The first thing is you sort of visualize them, they become real in your mind, and then you're able to take that very important step to analyze, how did that character feel? What was his motivation for doing it? Things that get into higher order thinking like inferences, and also extend into empathy. And empathy is such an important life skill and something that will develop if we plant the seeds for it. I've referenced here Edward de Bono's work, his Thinking for Action book, and he advocates developing the roots of empathy or perspective taking in children using something called the logic bubble. So I'm very big on games that emphasize perspective taking and looking at the other person's viewpoint. And one of the things I use is barrier games, and another one is called Tell and Show.
Tell and show, tell and show. We can't see, we can't see.
I brought my doll.
There's a doll in there for tell and show? Can you tell me about your doll? Tell me so I can see a picture of your doll in my mind, because I can't look at it yet, right, Mom?
You can't look at
That's
Miss
a
Amy.
rule.
That's a rule.
Okay.
Let's peek, and we'll pick something we need to tell Miss Amy, but we can't show her.
Okay, she has brown hair with bangs.
What's that? And a bow.
She was wearing a bow in her hair like you? Is it like your bow, pink and yellow? Your favorite colors?
It's orange.
Oh, the doll has an orange bow, and you have pink and yellow bow in your hair.
And she is wearing 2 bracelets.
The doll's wearing 2 bracelets? Oh, I can't wait to see this.
And pink and red.
One bracelet is rainbow colored, and one bracelet is pink and red. Is that right? Is that what I should be seeing in my mind, Mom?
Yes.
Okay.
She has blue eyes and a big.
She has big blue eyes. Oh, Kennedy, she has big blue eyes.
She has big blue eyes.
Mommy, she has big blue eyes.
She has big blue eyes.
I think I'm ready to see it now. Okay, let me see. Oh, wow. I didn't see in my mind that she was made from cloth. She's very soft. She's made from cloth. I thought maybe she was hard plastic. So I was seeing that part a little bit different. And you're right. Her eyes are so big, Kennedy. They're huge.
So you can see that her words made me form a picture in my mind, which I kept reflecting on, but I couldn't see the actual object. I had to form a mental image of the object based on Kennedy's descriptions of it. And then when I actually see the object, I reflect back about how my image is not the same or is the same in certain ways with the object. And this can be a really effective way to help children see that language and imaging is part of how we develop a fuller understanding of our world. I mentioned barrier games is one of the techniques I really like, and that they just involve two identical sets of objects that are the goal of which is for the clinician and the child to make the exact same design, no matter what materials you use. These are magnetic boards you'll see with felt boards too, but we can only do this through language. We have to take the perspective of the other person, and we have to use very precise language in order for our designs to match. So here's with the magnetic boards, and here it is with felt boards. And you're going to see a child with bilateral implants, and we are doing this activity together.
Remember that since you're the teacher and you're giving the instructions, you put one thing on the board, tell me where to place it, and then we'll and then say, okay, let's check, and we'll see if we've done it the same way.
Okay.
You have to use good descriptive language. I'm ready.
Okay. Put the boy on the board.
Okay.
In the middle.
Okay, good.
Then put
Excuse me. After each instruction, we check. The boy should be in the middle. Let's see, is he about the same?
Yeah.
You know what would help is if you tell me where, no, you don't change yours because you're the teacher. Yours is right. Mine's not quite like yours. It helps if you tell me where his toes should be. Because my boy's toes, excuse me, because my boy's toes are touching the bottom edge of the board. Is that the way you wanted it?
No.
No. So tell me where his toes should be, honey.
Right there.
Oh, I can't see your board.
His head needs to be on the blue.
His head should be, that's a very good way to describe it. Right at the edge of his neck and head on the blue line. Beautiful. Okay, what's the next one?
Okay.
So we continue in building a picture where he's giving me very precise descriptive language and hopefully developing this perspective taking where you can kind of see something from someone else's viewpoint. One of the things that happens in this video later on is Danny tries to tell me to put something on the board. And this is what he says: put the girl to, so the head, make the yellow blonde girl of hair, blonde girl hair, touch it, the blonde girl. So you can see that his organization of expressive language has a lot of work to be done. He is not proficient at what Daniel Ling called feeding forward, kind of preparing for what he needs to say, organizing it in advance. And I'm happy to say that that's going to improve over time. Given that I know what happened with Danny, it's a nice feeling to know that he improved, but to look back and see that he had a long way to go. Another thing to do with viewpoint taking or empathy is the use of poems, because they're very short linguistic bits of information, but they really pack a punch. So I might read this poem with my students. They said, come skating. They said, it's so nice. They said, come skating. I'd done it twice. They said, come skating. It sounded nice. I wore roller. They meant ice. So then we'll read it together and we'll have a perspective taking session. I'll say to the child, what did the boy who invited our character mean when he said, come skating? What did he mean? What kind of skating did he mean? And we'll talk about that. And then we say, and the boy who was invited, what did he think the other boy meant? So we're really dealing with theory of mind there, analyzing that different people have different ideas, and to be able to take the perspective of each of the persons represented in the poem can be really helpful. I mentioned categorization and how important that is for being able to organize our language world. Being able to categorize is a foundational skill for many other tasks, like being able to list attributes, to define words, to take effective notes, to group things together. And certainly when we categorize, we need to be flexible because not everything belongs in one category. In fact, nothing in the world really belongs in only one category, right? Things get grouped and then they get regrouped. So here's a really good game for kids called 3 for Me, where we play back and forth, and I'm going to pick 3 pictures and decide how they might group together. So I've picked a steaming teapot, mittens, and a bathtub, which actually also has a hole in it, but it's got hot water in it. And so I might say these 3 things are alike because they all have ability to keep you warm. And then the child might take his turn and take the bathtub and also group it with, because remember it has a hole in it, a smoking television and a broken pencil, and say these things are all alike because they need to be repaired. And so we find that things can be in many different categories at the same time, depending on what they're grouped with. So I'll just finish up here. Another category task is to take an academic premise that the child's working on at the time. Maybe in science lesson, they're working on living versus non-living, and saying, I'm going to say some words and you tell me if they're living or non-living. We categorize those, right? We could do this as an auditory only task, or we could do it as a spelling task plus a category task, so that it serves many different purposes. I could use academic content from geography or from math or from science, from language studies. I'll say a word, you tell me if it's an adjective, verb, or adverbs. And you could certainly have more than 2 categories, as you see there. Okay, music is our memory magnet, and you'll never remember anything longer than something that you sang, particularly if you sang it as a child. So be sure to use music cues. In your work, you saw me singing along with Kennedy, singing the rules to tell and show as a reminder of how we play it. So just to finish up, in addition to working on Boss Your Brain strategies in therapy, it's very important that families reinforce these and use them in everyday life, and that the child use them in school. So I am constantly providing carryover activities for parents to use at home and for the children to use in school as well, because we know the evidence suggests, and Bill Cronenberger's data show, that the most effective way to improve these skills is when we have carryover at home of things that have been taught in therapy. So I'll finish by saying, I've shown you snippets from therapy, but remember that our ultimate goal is not for kids to be able to do these Boss Your Brain techniques in therapy. It's actually for them to do it in therapy so that they can then utilize the strategies efficiently, spontaneously in the real world, in all the aspects of their daily life. Thank you so much for your attention, and best of luck to you in your work.
That was a wonderful presentation by Amy. I think some of the takeaways were all the different strategies that she's given us. The re-auditorization, the visualization, the different games that she's demonstrated to us through her videos, the categorization, the, even the different things, the carryover that people can do at home, the parents, that they can do these things at home. So I think it was a truly awesome presentation, and I think a huge round of applause to her from me. If there are any questions, Rashmi?
No, there have been no questions, and if something comes in, then we will later on send it to Amy. But thank you for chairing the session, and I do agree with you that Amy's was a very wonderful and a very practical presentation, which has a lot of takeaways for us, and probably we can start utilizing it in our sessions.
Absolutely.
So thank you so much. It's been a long day, I understand, but thank you for taking the time for chairing the session. Thank you so much. So that brings us to an end to the rehabilitation sessions for today. And now we will be moving on to the surgery hall for a common session, which is the Abbott Symposium. Post that, we'll have the GBM at 6 o'clock. And tomorrow we'll be meeting early for the posters and then later for the oral presentations. And post that, we'll have the main conference. So, thank you. Have a nice evening, everyone.
Please stop recording.
Sorry, just another housekeeping note. The e-poster session is not for viewing and is a closed door judging that is going to happen. But the oral presentations will be available for viewing. And you all can log in for seeing the oral presentations. Thank you.
Venu, you're there? Can you please stop the live stream in Rehab Hall?